Hello and welcome to Ovarian Cancer Maintenance Therapies. I'm Stephanie Blaufarb. I'm the Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little about SHARE. Improves the lives of women affected by breast or ovarian cancer through experienced peer support, accessible education, and innovative outreach, always for free. It meets women wherever they are, and especially in medically underserved communities, with the insight of women who have been there too, creating a nationwide network where women are empowered and feel less alone. SHARE services include support groups, educational tools, expert-led webinars and presentations like this one, a national helpline, online communities, and survivor patient navigation. For more information, visit sharecancersupport.org. All participants will be muted during the presentation. When the presenter finishes, we will open up for Q&A. During the presentation, at any time, and also after, you can enter questions in the question drop-down on the webinar pane, in the GoToWebinar pane. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. So now to introduce our speaker, Dr. Maurie Markman is a nationally renowned oncologist with a focus on patient-centered care. He is President of Medicine and Science at Cancer Treatment Centers of America. Dr. Markman has more than 20 years of experience and leadership in cancer treatment and gynecologic research at some of the country's most recognized facilities, including MD Anderson Cancer Center, Memorial Sloan Kettering Cancer Center, and Tulsa Cancer Center. So join me in welcoming Dr. Maurie Markman. Thank you.
It's a pleasure to speak with you this afternoon on the topic of ovarian cancer maintenance therapies for long-term survival. I just realized I am not able to move the slides forward on my, are you able to move them? Because I am.
What if you right-click on it?
Let's see, maybe, okay, that'll do it. I'll just right click, that'll work. Okay, so let's, first of all, it's important that we define what maintenance therapy is, and importantly, what maintenance therapy is not. The goal of maintenance therapy, or you could say the definition of maintenance therapy is, as the word states, to maintain an existing response. And from a trial terminology perspective, that is generally the statement is to prolong progression-free survival. So the idea is that there would be a response to some type of a therapy. Could be what we would state as a clinically defined complete response or a partial response to some type of response. And then the idea is maintaining that response. Importantly, this concept is inconsistent with the idea of some type of an intensification strategy. So if an individual had a response and you say, now we are going to treat much more intensively, as one might do, for example, in the management of an acute leukemia after a response, and potentially have many more side effects, that term used would be consolidation. So this is not to consolidate, it's to maintain. And that has significant implications with the question of quality of life. So this maintenance strategy is consistent with the idea of prolonging survival, although this may be difficult to prove in a randomized trial, in that if a patient goes off the trial and receives other therapies following this strategy, they may impact the ultimate survival, which is why the endpoint in such studies has got to be within the trial for progression-free survival. And again, this concept certainly supports the idea of maximizing quality of life. So with this background, you might initially say, well, why doesn't one always just continue therapy? Why would you stop it? Why wouldn't you inherently want to continue treatment to maintain response? Unfortunately, and specifically in ovarian cancer, there is an older experience that actually goes back 20, 30 plus years, where in fact, older alkylating agents were given indefinitely. These were oral agents. This was before the days even of platinum. Therapy might have been continued. In fact, routinely it was continued for 18 months or longer. And we now know that there were a substantial population of women with ovarian cancer who, in fact, in retrospect, their disease, their ovarian cancer, was cured. We know that because at autopsy, there was no ovarian cancer found, but in fact, they died of secondary acute leukemia. So, important point here is that these drugs we're talking about not only have short-term side effects, but long-term side effects, and therefore the idea that just continue this potentially toxic medication has a real concern. So there are other long-term cumulative effects that we know about for anti-cancer therapies. Cardiac, particularly the anthracyclines, such as adriamycin, peripheral neuropathy, common with the platinum agents and paclitaxel, renal dysfunction, particularly cisplatin, and of course, fatigue that may persist a relatively long term. Therefore, you have to then ask the opposite side of the question, why would you even consider maintenance therapy? I've just told you all the reasons why you might say, this doesn't make sense. A lot of side effects, potentially some of them very serious. So the flip side, and now this gets us into the world that we're in today, we know, and certainly ovarian cancer patients know, their families know, that overall, platinum-based chemotherapy is associated with a very high objective response rate. In fact, in the frontline setting, it's 80% plus. Lower response rates in the second line, third line settings to platinum, but in fact, still substantial objective response rates that you can measure by shrinkage of tumor masses on imaging studies, by CA-125, and most importantly, improvement in symptoms and quality of life associated with patients' symptoms they have associated with the cancer. On the other hand, there's also a high recurrence rate, and therefore, now we get back to the idea of maintenance, the goal would be to extend the duration of progression-free survival following the attainment of a response. And again, that could be measurable disease, symptoms, or both, and also to favorably impact survival in this setting. So what is the evidence to date for the clinical value of maintenance strategy in ovarian cancer? There's actually some older experience looking at platinum agents where there were actually randomized trials that looked at the question of 5 or 6 versus 10 or 12 cycles of platinum-based chemotherapy. So one trial might be 5, half the patients got 5 cycles, half the patients got 10. Another trial was 6 versus 12. And basically, these studies showed no difference at all. So there isn't any evidence today that giving more than, let's say, 5 or 6 cycles of platinum in any one regimen, obviously you might give it at the time of recurrence, but at one time, you get 5 or 6, there's no evidence that giving 8 or 10 or 12 is better. So with platinums, we don't have evidence of giving more cycles is better. With paclitaxel, there was actually some very interesting earlier experience, non-randomized experience, suggesting possible benefit. And then there was a large phase 3 randomized trial that looked at the question of 12 cycles of single-agent paclitaxel following completion of primary platinum chemotherapy. So the goal of this was, again, a maintenance therapy given once a month. And there was in this study, published a number of years ago, the first trial to demonstrate unequivocally an improvement in progression-free survival associated with this maintenance strategy. But unfortunately, there was also a considerable risk of clinically relevant neuropathy. So again, turning to this question of the value of maintenance therapy, it would be to maintain a response. But if you maintain that response and significantly decrease quality of life, then one must really ask the question, well, what is the value of that strategy as opposed to stopping all therapy and then potentially returning to treatment if necessary at some point in the future? So again, this experience with paclitaxel was positive from the perspective of the disease process delaying its recurrence if it was going to occur, but not positive from the perspective of an overall favorable impact on quality of life. So what about existing evidence beyond the experience with paclitaxel? Well, we actually now have I guess I'll use the term tsunami of data in the last couple of years, and actually going back even a little further back than that, that has clearly demonstrated the potential clinical utility benefit of a maintenance approach. The first drug to highlight is bevacizumab, anti-angiogenic agent. There are 2 primary frontline chemotherapy trials that specifically looked at, again, this maintenance approach. In other words, you give platinum and Taxol, might even give it with bevacizumab, but then at some point you stop the chemotherapy and you maintain the response with single-agent bevacizumab. These trials have shown an improvement in progression-free survival. There are 2 trials looking at bevacizumab specifically in the recurrent setting, but in a setting where the patient may still have platinum-sensitive disease. So this is second line, where a patient has had a recurrence, they get platinum again after 4 cycles or so, could be a little longer. Stop the chemotherapy. There were trials that looked at specifically carboplatin and paclitaxel, trials with carboplatin and gemcitabine. In both cases, when bevacizumab was then continued as a single agent, there was a highly statistically significant improvement in progression-free survival compared to not giving the bevacizumab maintenance. And finally, there's a trial that looked at the combination of single-agent weekly paclitaxel or single-agent weekly or every 3-week topotecan or monthly pegylated liposomal doxorubicin, all combined with bevacizumab versus these single drugs given without bevacizumab, and continued. The patient responded, but in this case, the chemotherapy and the bevacizumab are continued. They were not stopped. They were continued until progression, so to maintain initial response, again, showing an improvement in progression-free survival compared to the use of chemotherapy alone. And I think many know that there have been, over the last 2 years, now 3 PARP inhibitors, niraparib, olaparib, and rucaparib, that have been approved by the FDA as second-line or later maintenance therapy. Again, second-line, as you know, is any treatment, or second-line or later means any treatment after an initial recurrence. So these agents are approved in the maintenance setting, meaning patients will have then received a chemotherapy treatment strategy if there's evidence of recurrence. At some point, the chemotherapy will be stopped and the PARP inhibitor will be given in its place as maintenance. And that maintenance, these single agents, will be continued, of course, as long as the patient wants, as long as they are able to tolerate it, and until there's evidence of progression. In this case, as opposed to the bevacizumab I just mentioned, where the bevacizumab is actually given with the chemotherapy, and then the chemotherapy is stopped, the bevacizumab is continued. In this situation, with the PARPs are not currently given with the chemotherapy. They are simply started when the chemotherapy is stopped. We note that the improvement in progression-free survival is most pronounced, that improvement, in a situation where there is a presence of either a germline BRCA mutation or the presence of a BRCA mutation present within the cancer itself, but not in the germline. However, improvement has also been seen where there is no mutation in BRCA, so-called wild type, and the FDA has approved the use of all 3 of these agents, either in the presence of a BRCA mutation or in the absence of BRCA mutation. There are, in fact, trials ongoing, one of which is going to be reported. The outcome is reported, is my understanding, next month at the European Society of Medical Oncology meeting, and there are other trials pending that were looking specifically at this concept of maintenance therapy with a PARP inhibitor after the completion of frontline chemotherapy. So specifically to this question of whether one might use bevacizumab or a PARP inhibitor in the second line or later setting, important question because these strategies have now been approved by the FDA. First thing one would say is, of course, it's a patient's decision, a patient choice. what considerations might the patient, along with her advisors, family, or physicians, oncologists, consider? Well, as I mentioned, the bevacizumab is actually given with the chemotherapy, so the decision to continue the bevacizumab versus stopping it and giving a PARP inhibitor or not giving any maintenance therapy at all can certainly be informed by the tolerability of that individual patient to the bevacizumab. Now, for example, we know that bevacizumab causes hypertension. We know the bevacizumab there can be protein in the urine. I'm just using those as examples. If a patient had a lot of protein in the urine, or she had hypertension, it was difficult to manage, she had symptoms, that might be a decision that that individual patient would use to say, you know what, I am happy now that I have an alternative to the bevacizumab. On the other hand, an individual woman may have had no such side effects, and she might say, I feel very comfortable continuing with the bevacizumab. So that could be one particular item that could be included in the list of a decision to use to continue or not continue bevacizumab. The presence or the absence of a BRCA mutation might be used again by an individual patient in her decision to perhaps use a PARP or switch from bevacizumab to a PARP. Again, the FDA has basically said from their perspective, that decision is not theirs. They would approve the use of a PARP from their perspective. That is, the FDA's opinion on this. They don't determine medical practice, but they certainly present their opinion in terms of what the pharmaceutical company is able to say or not say in their labeling and their discussions. But the point is, an individual patient may say, I have a germline BRCA mutation, or my tumor has a BRCA mutation. I have looked at the data, and in this situation, there is a very substantial improvement in time to disease progression associated with the use of a PARP. I would stop bevacizumab, and even though I tolerate well, for example, and try the PARP. Another patient who doesn't have that mutation might say, I think I'll continue the bevacizumab and consider the PARP if necessary later. I'm just making up various scenarios to show how this information may or may not influence an individual patient's decisions. Patient may have a very strong desire simply to discontinue parenteral therapy. In other words, she may say, the bevacizumab is fine, but I'm really tired of going to the doctor and getting this injection, even though I love the doctors, I love the nurses. I don't want to do this, or don't want to do this as long as I can not have to do with it. So I refer oral therapy. Another patient may say, it doesn't bother me. I have no problem with it. In fact, it is reassuring to come in and talk to my doctor, my nurses about how I'm doing. And of course, there's always the question today, and this has to be completely individualized, the issue of cost, insurance coverage, copays, and particularly because in case of bevacizumab versus PARP, in one case we're talking about parenteral, and the other case we're talking about an oral therapy. And finally, general issues I sort of alluded to that are very important when it's maintenance strategies in ovarian cancer, necessarily unrelated to what I've just discussed, the long-term toxicities with some of the newer agents. I mean, we know about the long-term toxicities with the platinums. We know about the long-term toxicities with paclitaxel. We certainly know about the long-term toxicities historically with alkylating agents, because that goes back so long ago. Some of the newer drugs, we do not have really a lot of information. We have some information about long-term toxicities, but certainly not as much as we might have, let's say, 3, 4, 5 years from now. And of course, there's the important issue of low-grade side effects. And I use the example, as they're saying here, nausea and fatigue. And again, these are examples. They're hypothetical, but it's something that an individual patient will need to consider. And I'd use that example of, a particular low-grade toxicity may not be considered excessive during active treatment phase that's given over 4 to 6 months. In other words, let's say nausea. Grade 1 nausea for 2 days. I feel better. I've gotten 4 cycles. I can live through that. But if this was a side effect that was going to occur, again, low grade, but it occurred every day for a period of time, because remember, maintenance is continuous. And you won't stop unless excessive toxicities. It's not a four cycles, 5 cycles. But let's suppose that maintenance phase was a year, 2 years, 5 years. What impact would that have? Perhaps in this case, we're not actually using the term low grade appropriately, because it's a very different scenario, maintenance therapy versus treatment of active acute illness. And of course, again, final point is the cost of therapy and what that individual might have to pay for this therapy or their insurer over a long period of time. So those are the comments that I have to make. It's a very important topic. We are certainly going to be, I believe, seeing more of types of maintenance strategies, not only in ovarian cancer, but in other settings. This is good news because survival is being substantially prolonged. But the key here is that the prolongation is also associated with very satisfactory quality of life. And that quality of life is defined not by some textbook or some article or some arbitrary number like grade 1 or grade 2. It's defined solely by that individual patient, in this case, an ovarian cancer patient, so I will say she, a woman, will decide whether the quality of life is adequate, acceptable for her. So I thank you for your attention. I'll be happy to answer any questions you might have.
Great, thank you so much. Well, it's good we have lots of time for questions because we did get a lot of questions. So to start, are maintenance therapies available for clear cell ovarian cancer or other of the less common histological subtypes? Or yeah.
Yes.
Oh.
Well, I can only give the answer is yes. I mean, you can certainly appropriately ask the question of how effective they are, but that would be the same question we'd ask and we'd be concerned about the answer to in any uncommon subtype. Clear cells are a small percentage, but the answer is from an FDA's perspective and from the trial perspective, patients with clear cell were included, and there's no reason to say today that there's a reason not to do it. Of course, again, in the maintenance setting, it does imply that there has been a response to the chemotherapy because you're maintaining it. So in my opinion, as long as there's been a response, there's no reason not to consider these maintenance options.
Okay, and also I want to remind people that you can still submit questions in the question pane on the GoToWebinar panel. There's a little drop down where it says questions. You can click on that and you can enter them in the chat box. Okay, so what kind of progression-free survival is being seen with these maintenance therapies on average?
We're talking about medians now. So in the BRCA mutation positive population, some of these are approaching 2 years median. About half that duration in the non-BRCA type, still significantly better than the control arms in these trials, which were generally placebo. One wouldn't use placebo trials today, but you're seeing these are medians. So obviously that means half of the population is significantly longer than that. These are again, obviously it's the patient who decides what's impressive or not. My comment about being impressive is based entirely upon my experience as a clinician and as a researcher in this area for now well over 30 years. So I would say the results we're seeing are impressive. But again, that's as a researcher, a clinician, what the patient decides, again, with her advisors, what's important, what's not important, what's impressive, what justifies the potential toxicity of these drugs. But you're saying you may be seeing median. This is again from the time of initiating the therapy. So then you add to that the time of chemotherapy, which again is the chemotherapy. But if you're talking about the time of progression, you add another 4 to 6 months to that. Median. So again, median is not a person. Median is a number. Half of the people longer than that, half of the people shorter.
Yes. Okay. And also, you had mentioned the BRCA versus wild type. So what are there efficacy differences for people with genetic mutations or without genetic mutations?
Yes, I mentioned that. The difference is there are, again, the median, there are substantial, much greater, again, statistically significantly greater improvement with a BRCA mutation, either in the germline or in the tumor itself, compared to the non for the wild type or the no mutation, but there are still benefit with the no mutation, with that wild type.
Okay. And when should a patient be getting on a maintenance therapy, or when should they be, well, let's talk with when and why should a patient be considering maintenance therapy?
Why? Because they want to maintain their response that they've responded to. It's their decision. The idea is to maintain the response. When would be, again, based upon when they've already responded to a treatment and it's time to potentially stop the chemotherapy. But obviously the goal here would be to have that discussion with the oncologist and talk and think about the options. So it's not, you're here today, you make the decision today. The patient in a maintenance strategy, you have time to think about it. The patient's now gotten the stage, for example, the patient's had 3 cycles of chemotherapy. To just say this, she's had a really nice response. She's planning to get another couple of cycles. She can begin to talk to her oncologist about the pros and cons of maintenance, how many cycles of chemotherapy, what are the maintenance strategies. She can think about it. So that would be the idea.
Okay. And so if somebody tries a maintenance therapy and then it doesn't work for them, can they try other types of maintenance therapies?
Yes, they certainly can.
Okay, great. And so I'm just trying to sort through all these questions. There's a lot of them. Is there differences between capsule and tablet forms of, this is for a certain PARP inhibitor. I'm not familiar with that, but. Not really. I mean, the numbers of pills have gone down. There's, certainly, I'm not the one taking them, so it's obviously I always say, well, no, well, I haven't taken them, but in general, the answer is no. The original iterations of some of these therapies, the first PARP inhibitor that women actually had to take 16 pills every day. We're down to, a couple of pills a day. I think 4 may be the maximum. So it's, that's spread out over the day if you're taking 4. So in general, the answer is no. This is from that perspective, from the perspective of the, how many pills you got to take, that sort of thing. That seems to be pretty reasonable, compared to other medications that someone may take that if they take orally. Okay. And this, I'm not sure if you can answer this question, but somebody has asked, how do patients typically fare on these therapies with respect to being able to continue working? In general, that's exactly the point. It's a really important question because the goal is to do what you want to do. And if an individual, let's say, were bedbound because they were so sick, that made no sense. So the answer is and the quality of life studies that have been done as part of these trials would suggest what I just said is true, meaning that individuals they're at a certain point when they finish their chemotherapy. Presumably they are, they feel better. Again, their symptoms are better. Otherwise, again, I keep saying by definition they have to have a response. And they're feeling pretty good. The question is, can they maintain that? And the data would suggest the answer is yes. Now, obviously, there are individual patients who, unfortunately, don't fall into that category. They have excessive fatigue. They have excessive nausea. So obviously, that happens. The data would suggest that 85, 90% of patients who go on these PARP inhibitors are actually able to take them, tolerate them very well. Maybe 10 to 15% eventually, go off because of side effects. That's not a bad batting average, 85 to 90%. On some of these individuals are taking these drugs now for many years. I mean, again, when I talk about many years, I'm not talking about 1 or 2. I mean, maybe talking 3, 4, 5, 6 years. Again, the reason they're taking it is because it's working, not because they got to do it. It's helping. Yeah. Okay. We did get one request to speak slower, so I think I'm just passing that on. And then, are PARP inhibitors only available for platinum-sensitive individuals?
Not necessarily, but that seems to be where they are most effective. There are some data that shows they may have activity, excuse me, in platinum resistance, but like a lot of the data in ovarian cancer, where tumors respond to platinum, they're more likely to respond to other drugs. So this is not surprising that would be the case with the PARP inhibitors. But it's not an absolute by any means.
Okay. Has there been any studies on maintenance therapies for the BRCA1 mutation?
Not specifically that I'm aware of.
Okay. Okay, now I'm going through my questions, see what we haven't answered so far. Are you familiar with differences in cost or insurance coverage between maintenance therapies? Can you speak to that?
No, I think the biggest, I would have no reason to believe that, for example, the 3 FDA-approved PARPs, is my understanding the costs are similar, but the real question, of course, is insurance coverage, which I think Gwen's alluding to. I don't know, I have not personally heard of any differences in insurers covering one or another. The other question that I sort of alluded to in my presentation is we still have, there's this, in some insurers, again, remember, this is a country with hundreds and hundreds and hundreds of different insurers. Some insurers might cover parenteral medication, injectables, whereas they might not cover or not cover to the same degree or may have higher copays, for example, for oral. So that is an absolute individual discussion with an insurer. But in general, these drugs are FDA approved. Everything I've talked about is FDA approved. And therefore, I think that's a very important component in terms of the question of payment. But the distinction between, a copay for an oral or parenteral, that may vary from an individual insurance. And again, I think those are very important questions. I should also add, certainly all of the companies involved here do have patient assistance programs. Obviously, I'm not speaking in anything specific, but I'm certainly aware that pharmaceutical companies that have new drugs and novel drugs, patented drugs, do have assistance programs, which are going to vary from company to company and indication to indication. But that's obviously something that needs to be looked at as well, or potentially needs to be looked at as well by an individual patient, her family, and the oncology team.
Yes, that's a good point. We often recommend when folks call the helpline that they go to the website of the pharmaceutical company of the medication they're taking and look to see for assistance programs, because most of them do have that. Yeah, that's a really good point. So let's see. We had some questions about dosage. Can you speak to what is the efficacy versus side effects, and how does patient weight go into that decision for the dosage?
Yeah, the current, again, oral medications are dosed very differently than parenteral. When I say parenteral, it means injectable. The injectable, obviously, it's a liquid of some form. You can make it up based upon the, basically you could take, a syringe, you could put in a certain amount, a little more. You understand what I'm saying? Obviously, a pill is not like that. It's 100 milligrams, 200 milligrams, 300 milligrams. So that is based upon a person's weight to some extent. But the fact of the matter is that that varies. And of course, the absorption is going to vary based on, the drug. So in general, there's a starting dose for each of the drugs that is felt to be generally tolerable. And then the oncologist will modify that, not higher, but generally lower. So I think, again, the data from the drugs suggest that overall, they're all 3 of the PARPs specifically we're talking about are actually quite well tolerated. But dosage adjustments are very common. In fact, the majority of patients will eventually, again, everything is kind of the majority. It's not the individual. I can never say about that individual patient. The majority of patients do have some dose adjustments. It may be after the first dose. It may be first month. It may be after the 10th month. But that is obviously based upon blood count, hemoglobin, white count, platelets, but also how the patient feels. So I think a general statement, general answer to your question is the dosages are very well thought through for that average patient, including height and weight. But they're an individual oncologist, based on the experience they've already had, the patient's already had, they modify that dose at the beginning, or they may quickly modify that dose as treatment progresses based upon laboratory parameters and how the patient feels.
Okay, great. We had a question sort of for a clarification. So I think I will read this person's example. They said they responded well to first-line treatment, and the oncologist did not recommend or talk to them about maintenance therapies. So is that a normal?
Well, the PARPs are not approved for maintenance therapy after frontline. The only drug that is potentially used in maintenance would be bevacizumab. I obviously don't know when this would have occurred. Bevacizumab was actually only recently approved by the FDA. So if we're going back more than a year ago, there would have been no drug approved for maintenance therapy in frontline.
Okay.
And today there is no PARP approved in frontline maintenance. Again, that may change in the near future. It may not. We don't have data yet.
Okay. So this is for after frontline therapy.
Well, after frontline for everything except for bevacizumab. Bevacizumab is approved to frontline, but only relatively recently.
Okay. So maybe if there has not been a complete response and you're looking for, you may want to talk to your oncologist about it, that kind of thing.
Yeah, absolutely, absolutely. I can only give very general comments, but obviously if someone's concerned, they should definitely talk to their oncologist.
Right. Okay. Let's see, what else? So there are a few different PARP inhibitors. What are the differences between them?
Well, they're different drugs. They have a slightly different side effect profile. There's a little difference in the way that one of the drugs is taken once a day, the other two are taken twice a day. I think this is, again, one of these questions where an individual patient and their family need to talk to the individual doctor about the drugs and about them and their side effects, because what they've experienced that may very well influence the recommendation. So from an efficacy perspective, the drugs are really, again, there's no direct comparisons of one PARP to another. I can tell you that. But in terms of their individual trial results, they're all, as I suggested, very impressive. But what drug for what individual patient? They are different, a little different. And again, efficacy, they're similar, they're a little different. That's got to be a discussion between the doctor, the oncologist, and the patient. And again, that's not only going to include the data, but it's also going to include the experience of the patient already, side effects, etc.
Okay, yeah. Good things to think about and to talk about with your oncologist. Now, let's see, just looking over my questions, make sure I didn't miss anything. Okay. So I'm going to ask my colleague Andrea to ask this question. She's written it out for me.
Hi, Dr. Markman. Thank you so much for doing this. We've heard at some of the conferences about research of therapies or ways of looking at what causes PARP to be not effective, what is and ways to overcome resistance in PARP inhibitors for women in whom they previously have not worked. Do you have anything to add about that?
No, this is a very important area. It's an area under active investigation. There are questions, for example, as noted, there are now 3 available PARPs for maintenance. If a patient were to respond, this is a question I'm asking because we don't have an answer, but it's an important question, so I'm trying to point out, is if a patient received one PARP, responded to it, and let's say stopped responding to it, would it be worthwhile trying another PARP because they might respond to a second PARP if the first one stopped working? That's a very important question. We don't know the answer to it. I'm sure it's being looked at. Same thing with side effects. If the patient had excessive side effects to one part, might a second side effect, while the second part have less side effects for that individual patient. We don't know. It's got to be looked into. The mechanisms of resistance. Tumors are very smart. They figure out a way of getting around it, and there's a lot of work going on to try to figure that out. Combination therapies, PARPs and angiogenic agents, PARPs and checkpoint inhibitors. There's a lot of research ongoing that is going to inform us in the future. Not a question about it, but my answer is very active area of research.
Great, thanks.
Great. How would a decision about maintenance therapies change if somebody had had a full response versus a partial response after their first-line treatment?
Not in terms of the trials. In terms of the data from the FDA, there's both of those would be a reasonable option.
Okay. Let's see. Are these maintenance therapies appropriate? Like, does the staging, early stage versus late stage, differ in the decision making for maintenance therapies?
Not in the second line setting, because in the second line setting, the tumor would have already recurred.
Okay. Great. I think that's most of our questions. Actually, there's a couple more general questions that I want to ask you since I have you and people are asking these questions and they need some clarifications. What are some, how would a woman know that she's experiencing a recurrence and what kind of monitoring goes into that with your oncologist to monitor that?
The major monitoring strategy is CA-125, and of course, if a patient has symptoms, she has abdominal pain, bloating, like the initial diagnosis, she should see her oncologist. Doesn't mean it's necessarily it's recurrence, but that's basically the symptoms of initial symptoms are likely to be the symptoms that occur again in the presence of recurrence. But the monitoring in general, the CA-125 is the simplest strategy to follow.
Okay. So I guess, we sort of covered this a little bit in our talking, but I think to sum up, I'll ask you one last question, which is what sort of questions should a patient bring to their doctor to start talking about maintenance therapies, or what kind of?
Just, if I'm responding to treatment, is there an option after I finish the chemotherapy? I understand there are drugs that are approved for that purpose. Do they make sense for me? You could even bring in the names of the drugs and the strategies, but I think just a more general question is perfectly fine. I'm doing well now. I've had a good response. It's great. What might I be able, just use the word maintain. What might I be able to do to maintain this response? I understand there's options available. And again, let the doctor discuss it. You ask the questions, let the doctor answer. May not have all the answers. Let's see how you are in a couple of months. Let's consider the options.
Great. Okay, that's all of our questions. Thank you so much. This has been really great. We really appreciate, and I think the response, people have been submitting a lot of questions, which also goes to show how much people appreciate you giving us your time to answer all these questions.
It's my pleasure. Delighted to do so.
Oh, good. And thank you all for participating and submitting your questions. Please take a moment to fill out the survey at the end of the webinar. This is being recorded and it will be available on our website. We'll be emailing a copy of this to everybody who has registered, and I'm also hoping Dr. Markman will, he's already shared his slides, so we'll also send out the slides as well. All right, so thank you very much, everybody.
Thank you. Thank you all. Bye-bye.